Hello, I'm Doug Wood, the Chair of Surgery at the University of Washington, and today we're going to be talking about disparities in lung cancer access to screening. And I have with me three experts on the area, panelists from different academic institutions around the country. And I'll just ask each of you to introduce yourself. Dr. David.
Hi, I'm Elizabeth David. I'm a general thoracic surgeon from UC Davis in Sacramento, California.
Hello, my name is Betty Tong. I'm a general thoracic surgeon at Duke University in Durham, North Carolina.
Hello, my name is David Cooke. I'm head of general thoracic surgery at UC Davis in Sacramento.
So we're in an exciting era where we now have early detection for lung cancer through low-dose CT screening. And in fact, if fully implemented, low-dose CT screening could save 12,000 to 15,000 lives per year. But to do that requires people to be referred for screening, to be screened, and then to have access to care after they've been screened. There have been multiple studies that show disparities in access to referral for screening, and then access to screening centers, and to subsequent workup and even treatment for lung cancer. And so we want to address these problems in both access to screening and access to lung cancer treatment that exist in the United States. And that's what I want our panelists to talk with us about today, how we can identify and hopefully mitigate or overcome these disparities in lung cancer care. I'll start with you, Dr. Tong. What do you see as some of the reasons for disparities in lung cancer screening?
Well, I think there are several reasons for this. First is, as you mentioned, access to care. African Americans, Native Americans, and Hispanics are more likely to be uninsured than other patient populations in our country. And currently there is no provision for lung cancer screening for the uninsured. Pair that with the fact that smoking is more prevalent in these patient populations, and you really have a bad combination. Another issue is a matter of coverage for those who do have insurance. In my state of North Carolina, for example, North Carolina Medicaid does not cover lung cancer screening for Medicaid patients, and so that is an issue for us, and Medicaid coverage varies at the state level. And finally, for patients who do get screened, adherence to guideline recommendations for continued annual screening and follow-up may be challenging. There are studies in the literature that have showed that patients of lower educational status and self-pay mechanisms have a harder time adhering to annual screening guidelines than others.
So in a sense, coverage policy or insurance policy is maybe unintentionally a barrier rather than improving access for patients that might be candidates for screening.
Yes, I think it's a little bit of a mixed blessing. On the positive side, we do have coverage for lung cancer screening for patients who have private insurance or Medicare. But as I mentioned, those with Medicaid are at the mercy of what their state legislators think. Again, at our institution, because there is coverage, we are not allowed to have a self-pay mechanism for patients who might be able to come up with the funds for self-pay screening. Because there is coverage, we're not allowed to have a dual reimbursement model.
So Dr. Cooke, obviously primary care doctors are a key part of the equation. So how do you think lung cancer screening, the new access to lung cancer screening, is perceived by primary care doctors? Do you think they see this as a great opportunity for a preventive service for their patients, or is it just another burden to an already overworked primary care doctor?
Well, I think the issue with primary care is an issue of education and knowledge of what's recommended and what's evidence-based. I think for things like breast cancer screening and colon cancer screening, many primary care doctors have a really good grasp of the recommendations. But some primary care doctors do not understand that lung cancer screening is as recommended and as a key health population element as breast cancer screening and colon cancer screening. And if they knew that lung cancer screening is recommended for high-risk individuals, I believe many primary care physicians would reach out to their patients and ensure that. Now, some primary care physicians may see lung cancer screening as a burden, because one of the aspects of lung cancer screening are really novel methods to prevent overscreening, such as shared decision-making and insurance for smoking cessation. And I think there are many institutions that have policies to make it easier for our primary care and family medicine colleagues to implement lung cancer screening. That includes novel uses of electronic health record, lung cancer screening consultation mechanisms to help alleviate some of the burden of their practice and really help their patients.
So I'm aware that at least one of the major guidelines groups from the American Academy of Family Practice has actually recommended against lung cancer screening. Do you have any ideas why this is or how this may impact the issue we're discussing in terms of disparities of access to lung cancer screening?
Well, if you look at that group's recommendations, their calculus for coming to that decision is that there's not enough information or not enough evidence to recommend lung cancer screening. But the reality is that there is a plethora of evidence, including a large randomized multi-institution controlled trial that was performed here in the United States. And really, that ship has sailed. That ship has sailed, has landed across the shores, the people have gotten off, and they've all gone home. The evidence is clear. Lung cancer screening in high-risk individuals saves lives.
So, Dr. David, Medicare has required shared decision-making discussions, and Dr. Cooke just talked about that, and that this needs to be documented before patients are allowed to have lung cancer screening. Obviously, we want to educate our patients, and so that's the intent behind shared decision-making. But are there any negative or unintended consequences of this policy of shared decision-making?
Sure. I think, as Dr. Cooke was alluding to, that the shared decision-making component that is required can be a burden to some physicians. And it requires a certain level of education and comfort about lung cancer and talking to patients about lung cancer. And as we all are pretty comfortable with, lung cancer patients are very heterogeneous. And so talking with them about the risks, benefits of lung cancer screening naturally, inherently brings in a discussion about the disease, which can be complicated for providers to have who are not comfortable with the disease and the treatment options. So in a way, it can be a disincentive for practitioners to talk to their patients and offer them screening if they feel unprepared.
On a related issue, I know that a good part of your research has been in cultural dexterity. Mm-hmm. And what are the challenges that we have in having cultural dexterity and how we address patients of heterogeneous populations that are at risk for lung cancer? And how can we be better in terms of those shared decision-making conversations?
So I think this is really key in knowing your patients and understanding the perceptions that patients may come into these discussions with, and being aware of, as Betty mentioned, there are known educational and socioeconomic status disparities in healthcare. Being aware of those disparities and sort of placing yourself in the shoes of the patient, acknowledging some of the biases that may exist in their culture, and then also being aware of stigma and how it can impact lung cancer and lung cancer decision making. Patients may come with the preconceived notion that because they smoked, they did this themselves, and therefore they may be less eligible or, less deserving of treatment. And that is simply not true, and that's something that physicians need to be aware of and need to work hard to combat. And the best way to combat it is to acknowledge it.
That's great. Thank you for the advice. Dr. Tong, moving on to another area of geography. How does geography impact disparities in how patients may access screening centers or treatment for lung cancer?
So this is being studied by several groups, including our own. It seems intuitive that limited availability of imaging resources would be a barrier to access of care. At a national level, it's been shown that there is statewide variability in both the number of screening facilities available to eligible individuals, as well as the distance that they have to drive to get to those centers. In one study, the distance to any accredited CT facility was varied between 5 miles and 30 miles, depending on where a patient lived. Even at the local level, in our local area, there is uneven geographic distribution of patients who are eligible for screening, who might have other challenges in terms of getting to our facility.
Any suggestions or ideas on how to mitigate this problem? How can we try to make it so that rural populations that have a greater distance to travel, how could we improve their access to screening or to treatment for lung cancer?
I think one potential answer would be to bring the scanner to the patient. There was a study published in the British Medical Journal recently where in Britain, in a high-risk area and in a high-risk population who met NLST criteria, they parked a mobile scanner unit in the parking lot of a shopping center. They screened patients who were eligible, and I believe 80% of the lung cancers that were detected by screening were early stage. I think that that is a potentially attractive mechanism. I do want to stress the importance, however, of the shared decision-making and the discussion of the tobacco cessation with the patients at the time of screening. And I worry a little bit about staying true to that with the implementation of something like mobile screening.
And at your center, have you used anything like a hub and spoke model of having, the major center that has, thoracic radiologists, thoracic surgeons, that has a network of centers that may be doing scans and have pulmonary physicians that can evaluate patients, and there's a shared work between kind of smaller centers that are closer to where the patients are, but a central center that can help with the evaluation or treatment of those patients?
We have I guess I would call it a modified hub and spoke. We have a very active smoking cessation program within the institution that has many hubs out in the community. They refer to one of our 2 screening sites. Part of our screening model is that we do the in-person shared decision-making, and our providers are certified tobacco treatment specialists as well, so they do the tobacco cessation counseling at the time of the visit, and our patients get their scan results and a review of the study with that provider while they're in the clinic.
Dr. Cooke, how do racial or ethnic differences impact how patients may accept the principles of screening or be adherent to follow-up and annual screening, or be willing to undergo a workup for a potential and treatment for a potential lung cancer? Tell us about those differences.
So those differences can be complex, and it's important for the care provider to take on that complexity for the betterment of the patient. Getting into what Dr. David talked about, there's a notion of stigma, that lung cancer is a lifestyle disease, and you've made the decision to smoke, and therefore somehow you potentially deserve this cancer. And that is what some patients feel. They feel that sort of stress of that stigma, especially in communities such as the African American community. But what the reality is that many patients in these communities underwent targeted marketing for tobacco and lack of access to smoking cessation opportunities. And therefore, that sort of stigma should somehow be mitigated. The message I would say is that really as care providers, we approach our patients with a sense of empathy. I understand where you're coming from, and this is not a disease process that you deserve. No one deserves it. All you need are lungs to get lung cancer, and I'm here to help. And this is what we need to help you. And if you show that empathy, then that trust builds up. And the shared decision-making process is really working with the patient so the patient understands not only should they undergo screening, but if something is found, what should you do? Mm-hmm. And if a lung cancer is found, what should you do?
Dr. David, why is it important to have a surgeon directly involved in a screening program?
I think as thoracic surgeons, we are uniquely positioned to lead these programs and lead these initiatives. I think we have a very robust understanding of this disease from both the diagnostic and therapeutic approaches. And so I think that makes us uniquely positioned to efficiently help these patients through the system for both diagnostic and treatment options. And so I think it is absolutely crucial that we stay heavily involved and lead these programs.
So I'll take that a step further. So in a screening program, who makes the decision of whether a patient may be eligible for treatment? Who should be part of that decision? And how do we prevent bias or stigma or nihilism from impacting those decisions?
Certainly. So I think that in terms of making treatment decisions, I think for most lung cancer patients, and I say most lung cancer patients because most are not early stage patients, I think most of those patients need to be discussed in a multidisciplinary setting. And I think we know from several large studies that there are a lot of lung cancer patients who undergo no treatment at all. And it's important that we consider all treatment options, including palliation, for patients before we commit them to a path of no treatment at all. And I think we've discussed some of the perceptions and stigma that influence the decision to undergo lung cancer screening. Those same stigmas and misperceptions can influence treatment decisions and can likely influence such high numbers of patients being untreated.
Terrific. Thank you. So as you can see from this discussion with our panel, it's clear that patients at risk for lung cancer have actually suffered disparities in healthcare for a long time. In fact, this might be a reason that it's taken so long to develop approval for lung cancer screening programs, because lung cancer disproportionately affects the elderly, those of lower socioeconomic groups, and has poor outcomes in certain underrepresented minorities. Now that we have lung cancer screening as an option for early detection, for it to be successful, we have to assure that there's equal access for all patients to have early detection of lung cancer and then access for treatment of that lung cancer. Some of this depends on coverage policy, insurers, both private insurers and Medicare. But as you can see from the discussion, some of it depends on what we're able to do at the local level, both in organization of our programs, as well as the cultural sensitivity of how we care for patients at risk of lung cancer that we're screening and those that we identify with lung cancer who we want to turn into lung cancer survivors.